Welcome everyone to tonight's OTAC clinical case webinar. Tonight we have Dr. Julie Uwe, who is a neonatologist at the Royal Hospital for Women, Conjoint Professor of Paediatrics at UNSW, the VMO of Addiction Medicine at Murrumbidgee LHD, and also the lead author for the Clinical Guidance for the Management of Substance Use in Pregnancy, Birth, and the Postnatal Period. So before we begin, I'd like to acknowledge the traditional custodians of country on the lands on which we meet and recognize their continuing connection to land, waters, and culture, and also to pay our respects to elders past, present, and emerging. So these are the registrants for tonight. We have people from, I think, every LHD in New South Wales, as well as Adelaide and Hobart in Tasmania. We have a lot of people from Sydney Local Health District, but also it's great to see someone from every LHD, and also the roles and specialties for tonight. As usual, we have a lot of GPs and pharmacists, but also someone from every role. So welcome everyone to tonight's webinar. Just a little bit about the OTAC webinars. These are a monthly webinar that occur on Tuesday nights from 6 to 7. After the webinar, I'll send you a letter of attendance that you can use for CPD points, and the webinars will be recorded and made available on the OTAC website for viewing. And just a little bit about the OTAC scholarships. These are open to unaccredited general practitioners and nurse practitioners in private work settings in regional, rural, and metropolitan areas. And you can receive up to $2,000 based on completion of accreditation milestones. And there's more information on the OTAC website. And just some quick housekeeping before we turn it over to Julie. Please keep yourselves on mute unless you're speaking or asking questions. Feel free to put any questions in the chat if you'd like. And we have Dr. Sharon Reed who will be joining to monitor the chat in case of any questions. They are recorded, and also please be polite when you're asking questions or making any comments. So now I'll turn it over to Dr. Julie.
Yeah, thank you. As Jessica said, I'm a neonatologist and also an academic at UNSW. And also for the last 5 years, I've been a VMO in addiction medicine at Murrumbidgee, mostly based in Wagga Wagga. A very small fraction, about 0.1, but it's taught me a lot about the differences between rural health services and the city, where we have everything on tap, right? I was approached to do these guidelines, or I would say guidance from the ministry before COVID 2019. So it's taken quite a long time to come into what it's looking like now. It was actually finished in February, and Dr. Chant was reviewing it, and finally it came out last month. So what I'm going to do is I'm going to go through what has really changed between the last two guidelines that we've developed in New South Wales Health, the first one in 2006, the second one in 2014. All right. At any time, do please interrupt, put up your hand, or ask Sharon if you have any questions that you want answered right now. I guess what's really driving me was the story I heard from one of our lived experience. I'll call her Jody. She reached out to me when she was pregnant in a rural area somewhere in New South Wales, not named. And the interesting thing about Jody was that she was not what we would normally think of one of our moms. She was the director of research in one of the lived experience centers. She's a PhD student at UNSW, and she knew what she was talking about. But she was on the methadone program, and she wanted to find out some information to help her and her child when her child was born. And she had difficulties connecting with any clinicians for that. So she found me on the net. But when she did give birth, she was so shocked at what happened. She said a few minutes after her baby was born, a doctor barged into a delivery room to interrogate her. He asked her where were her medications, and she told him that she had her medications with her, and he rolled her eyes and said, "Yeah, that's a start." Made her feel really bad. And then the alcohol and other drug team would visit her daily in the 4-bedded room and discuss her treatment right in front of the other mothers. One of the doctors came into her room and told her not to fall asleep after a prolonged birth because otherwise docs will think that she was on the nod. She spent the rest of her time in hospital, terrified. And as her child grew, she had to find her own pediatrician. The baby had problems with his vision, had problems feeding, and she had to look for help herself. And really, there was no assistance. So, what went wrong? First of all, Jodie was not respected. She asked for help, but was not given any. But maybe because we didn't realize what we had to do. So would some guidance have helped us? I don't know. The good parts is that many of the health conditions, especially in addiction medicine, are not clear cut. And there are lots of moving parts with many players. Having a bit of guidance, I guess, will reduce the variability in the care that patients like Jodie and her son received, inform on the latest evidence-based management, and hopefully draw attention to ineffective, dangerous, and possibly wasteful practice. And maybe they could support some QI activities that would improve patient outcomes. However, if taken to heart and by, as gospel, guidance can also be harmful because the recommendations may not be appropriate for certain groups and be misinterpreted and also be influenced by vocal members of the development group and overtaken by new guidance. So people that the guidance are developed for, people like Jodie, often don't have a voice in the development of this management. And remember that guidance is not law, and you need to temper it with some common sense, with your brain, and with some compassion. So what were we using to help us care for patients like Jodie and the baby before this came out? So you'll all remember the clinical guidelines, a yellow book that was written, I think, in 2014, and added onto that was the neonatal abstinence syndrome guidelines that came out in 2013, which was the revision of the first guidelines in 2006. This guidance, these two guidelines confused every one of us. I know we were talking about the yellow book and then the NAS guidelines, but what it boiled down to was that much of the information in these two guidelines or guidance was very opioid centric. So they focus on opioid treatment and also the hospital care of the baby and the mother. There was little talk or little advice about what to do afterwards, and little advice about other substances or medications that parents with substance use disorders would be using. And the neonatal abstinence guidelines were due for renewal in September 2018. Oops. And the yellow book had no expiry date, like certain food products. Anyway, so no expiry date or being outdated doesn't mean that we couldn't use this guideline. So was there a major problem? Well, I myself found that the two documents were quite confusing. They were very opioid centric, and you know that recent changes have, revealed more methamphetamine use, more cannabis use, more antidepressant use, and there were difficulties in integrating mitigating circumstances. So if you've been on the floor looking after newborns, for example, those two guidelines recommend a minimum stay of 5 to 7 days. And often you hit a Friday, the baby's day 5, they're not withdrawing, they look excellent. And then you keep the poor baby in hospital, using up another bed for the whole weekend, and everyone's cranky. The assessment was only with the Finnegan scale. So I assume that all of you on the audience will know what the Finnegan scale is. And if you've seen the Finnegan scale, it goes up to like 31 items, drives the nurses mad, and it's been implicated in over medication of the babies in the States, over medication and prolonged hospitalization. Those two guidelines didn't take into account the families in different situations, such as those in rural and regional centers who are very far away from the clinicians that can look after them. So working in Murrumbidgee, I appreciated that some women had to travel 200-300 k's to get their baby seen by a doctor. Telehealth has helped enormously, but still, there were no facilities or no information to help families in those situations. And one of the big ones was foster parents. Foster parents are the backbone of many of our families, and often we get calls for help from foster parents who have had to, look after called to look after a baby late on a Friday afternoon with no information and with no direction to seek care. So we did not have the lived experience voice of foster parents in the development of the two other guidelines. So we started the process. It took a pretty long time. It started about October 2019. Then COVID happened and threw us all aside. But we finally finished in February this year. It was very exciting. And the process started by talking to a lot of people. At least, I think, 26 professional societies. I won't go through every single one here. And many, many experts, and really apologies to those I missed on this list. So we use the expertise, their knowledge, their lived experience to help us develop this guidance. So we did many revisions, and we are still revising. The beauty of this is that it's a live document. So we're still finding some inconsistencies. So if you do get a chance to read through this and you think that, there's something that you don't agree with, you think that we've said it wrong, please contact us because this can be changed. We advise you not to print it into on paper, not only because it's a waste of paper, but then whatever you have could be an old version, an outdated version, or an uncorrected version. So the major question was, did we need more guidelines or guidance? Has that much changed since the last iteration in 2013, 2014, 10 years ago? Things may not have changed that much, but we now hopefully realize that many people are involved in the care of families impacted by prenatal drug use. And this has a potential to account for more than 300,000 Australians in the world. None of us have any special training in this field. And I remember when I trained in pediatrics in the dark ages, right? Neonatal abstinence was one little paragraph in the pediatric textbook. We have very few services that have integrated lived experience input, and we really have little crosstalk between the disciplines that are needed to ensure good and safe care. But unfortunately, prenatal drug exposure is now or always has been a major public issue. And if you look at all legal, illegal substances, at least 1 in 20 babies may be exposed at any one time to a prenatal drug of dependency or addiction. If there are 300,000 deliveries in births in Australia per year, that's probably about 15,000 babies per year. So it is a serious health problem that may be potentially fatal. About 1.5% of Australian babies, so about 1 to 1,500 Australian babies may withdraw, mostly from opioids. And without treatment, it's well known that there is a high fatality rate. So it's critical that all the babies receive the right care. And I won't go through this in too much detail because it describes the evolution of treatment for neonatal abstinence syndrome since it was first described way back in the 1870s. And you can see with clinical and research energy poured into the treatment of neonatal abstinence syndrome, it's evolved from an almost fatal disease to one that rarely uncommonly causes direct infant death. But as a result, there are lots of children who are growing up with a history of neonatal abstinence syndrome and or prenatal drug exposure. And we're finding out more and more that they have problems that need to be addressed. And the three main ones are neurodevelopmental issues, late death, and increased risk of maltreatment. Another thing that is driving the changes in our guidance is that the type of drugs used today are different, and it's not all just about opioids. Many patients are using stimulants and other drugs that have a lot of different effects on the baby as well as the mother compared to just opioid use. In this study done by my student Taylor, what she did was she mapped prenatal drug exposures over 20 years in New South Wales and the ACT. So these are heat maps, and it shows the changes in drug use as indicated by hospitalization data for moms, death data, and also emergency room data. What we can see here is blue represents a decrease, and as you go more and more yellow, red, and orange and red, that's an increase. So overall, there's a decrease in smoking across New South Wales. Alcohol has mostly stayed the same, but there is an increase in diagnosis of neonatal abstinence syndrome and prenatal drug exposure, especially in regional New South Wales. So guidance must reflect and support regional and rural areas. Oops. From our studies, we have also shown, mostly using linked population data, that children with drug exposures have problems beyond the newborn period, beyond neonatal abstinence syndrome, and should be supported like any other child with a chronic health condition. So with our follow-up to 20 years, we've shown that children with a past history of prenatal drug exposure are more at risk of terrible issues such as failing at school, death, and increased healthcare use. If a child has a history of prenatal drug exposure, they are 3 times more likely to die than other children, especially between the age of 1 month and 1 year, and mostly from preventable problems such as sudden infant death syndrome and assault, maltreatment, and accidents. Our data has also shown that the prenatal drug-exposed children have poor school outcomes. So when you look at the NAPLAN standardized tests, by age 8, they are 3.5 times more likely to fail. By age 15, their tests are worse than children who are 4 years younger without drug exposure, age 11. So we need to have concerted effort to support their health and development, and there is almost none today. So another thing that we found was that women who gave birth with a history of substance exposure were significantly more likely to die within 5 years. So perinatal or obstetric reports of maternal death usually stop at 1 year. But if you go beyond 1 year, you'll see that moms with a history of substance exposure were more likely to die from suicide and from external causes such as poisoning, accidents, and trauma. So before we embarked on this guidance, we were commissioned by New South Wales Health and the Sex Institute in 2021. That was published in 2021 to do a rapid evidence check of what interventions there were to prevent these harms. So looking at a review of all these studies since 2010, our sad conclusion that there was no single evidence-based intervention that is able to prevent death, poor mental and physical health, social and economic vulnerability, and the lifespan and intergenerational disadvantage associated with prenatal drug exposure. So we recommended that future research and policy efforts must address the use of substances, not other than opiates, but in addition to opioids, longer-term outcomes beyond pregnancy and the newborn period, and to evaluate entrenched models of care to optimize the children's long-term health and safety. Ooh, sorry. So almost concurrently, the Canadian government funded an effort for the UNODC, or the United Nations Office on Drugs and Crime, during the pandemic to develop an informal technical report on how to help children who were survivors of prenatal opioid exposure. So we met together online, unfortunately, in 2022. And I was looking after the health section, Andre Jones, the social section, and Mishka Terplan, the education. And the results of this, after consultation with more than 40 people from 14 countries, were presented at the Commission of Narcotic Drugs in 2022. And again, the said conclusion was that there was no intervention able to prevent these harms. So a change of strategy we decided had to be needed to make sure that families with prenatal drug exposures were safe, and it is an intermingling of health, society, and education, and not only focusing on clinical care. One of my students, looking at the impact of out-of-home care, which is an integral part of our care for families with prenatal drug exposure, has shown that any contact with out-of-home care has the potential to decrease the risk of death by up to 75% in children in New South Wales. This does not mean that the children are removed from the care of their biological parents, but indicates that they can survive with support. And what was interesting was that we showed that any contact with out-of-home care could decrease risk of death from external and preventable causes in children with prenatal drug exposure, such as self-harm and assaults. And any contact with out-of-home care also reduced the risk of death from sudden unexpected death in infancy in the children with prenatal drug exposure. So what has developed and what is new in this 2024 guidance, apart from being really thick, so if you print it all out, you probably, kill a lot of trees. So the guidance was also developed from a systematic review of what existed for guidelines for neonatal abstinence syndrome that was recently published in the Children's Journal. So my student Zoe reviewed 22 guidelines that were published online worldwide. And we found that more than 3/4 of them did not meet standards for clinical use due to lack of evidence. Almost none of them provided guidance for non-opioid drug exposure, and almost none provided guidance for the care of the long-term health of the child. So first of all, we developed some information on non-opioid substances, including prescription meds. So we parceled them out into these major categories here. So as usual, alcohol and tobacco, and then the stimulants, cocaine, amphetamines, and then the benzodiazepines, gabapentinoids, opioids, cannabis inhalants, and antidepressants, SSRIs. The guidance was focused on the impact of the substances on the mother, on the child, and the treatment of neonatal intoxication and withdrawal from specific drugs. So this takes the focus of the care away from abstinence, because as you know, in some of these medications, the effects of the drugs on the infant is an intoxication rather than a withdrawal. We also incorporated a lifespan approach with lived experience input. So with very important voices like Jody and other people like foster carers, we focus on the continuity of care beyond birth. We recognized there were new considerations for vulnerable families, some of whom were homeless, impacted by violence, First Nation families, rural and remote communities, those in custodial settings, LGBTIQ plus families, and very important, foster parents. We incorporated legislation on child protection services, including advice on newborn drug screening, which is always a very difficult area on the floor during the clinical care of a child. Importantly, there was input from trauma-informed care experts into how we could develop this guidance to be safe, to be trusted, and to allow patients to have a choice, and for them to collaborate with the clinicians to empower them in their treatment choices and to have respect for their culture, gender, history, and identity. There's a lot of emerging evidence that I may not have time to talk about, and we have included what we know about buprenorphine and naloxone, depo-bub, and medicinal cannabis. Medicinal cannabis is used increasingly now, and the bottom line is our advice is that health workers should advise women that the best option is not to use cannabis, even if it is prescribed, and that quitting during the first trimester is ideal. So this is a pathway of care that we suggest for any infant and child that's known to be exposed to prenatal bugs in the ideal situation until they reach school age. We emphasize that non-pharmacological interventions, or NPIs, are paramount. So if you have the capacity, help the mother and the infant diet, room in, support with small frequent feeds if there's a chance of withdrawal, breast milk feeds with swaddling and nursing in a quiet environment. Many of our hospitals can't afford to do that, but hopefully, with some, funding or some vision from the administrators, we may be able to help us achieve this aim. So if non-pharmacological interventions are unsuccessful in preventing escalation of withdrawal, then medications are recommended, and we give guidelines on what type of medications to use, including morphine, phenobarbital, and clonidine. So when the child goes home, what we recommend is like for any child with a chronic problem, or for example, a baby who's been sick in the neonatal intensive care unit, that surveillance and follow-up and support continue. So we recommend that by 1 year of age, hopefully the child will have a developmental check every 6 months, because we have shown that, some of the children, especially those who are exposed to opioids, may manifest early signs of developmental delay from as early as 6 months. We recommend an eye review. We've shown that babies who are exposed to opioids especially may have a 10-fold risk of eye problems that are easily correctable, such as strabismus or squint and myopia, that if it's not corrected may really impact on their future learning ability. And of course, if there's a risk, for example, with hepatitis C or B or HIV, keep a vigilant check on whether there's been some vertical transmission. What we hear on the ground is that many children who have been impacted by prenatal drugs may have difficulties with coordination, muscle control, and with, daily tasks like writing. So by the time they reach school age, an allied health referral might be beneficial, as are continuing neurodevelopment, mental, and physical health checks.
Julie, can I interrupt for a sec?
Uh-huh.
I was just wondering, practically, how do we ensure this follow-up over time?
Wow, that's a
What are the
$1 million
strategies?
question. That's a $1 million question. I think what is really important is for us to raise awareness of the issues that these children have. So, like for example, in Tennessee, on the back of our studies showing that the children with neonatal abstinence had terrible school outcomes, Tennessee has advocated for a diagnosis of neonatal abstinence syndrome as an indicator for extra academic support. So I think we need to take away the stigma that will allow us to enable these children to receive the help they need. A lot of times people don't admit to using the substances, and the children go underground, they get lost, right? But if we can draw attention to the fact that these kids need help, then hopefully we will get the resources to allow them to get this help. Michelle.
Yeah. Yeah, I guess I'm just thinking practically.
It's so
How do-
difficult, isn't it?
Yeah,
Yeah.
it's very difficult, and I guess at what points in the system, like certainly after discharge from, so they're in the neonatal unit, and then there's follow-up, and then often the kids would be referred to a pediatrician. Is that right? Or...
Yeah, so the trouble with many of our children who have been exposed to drugs, right? They look really healthy when they leave the hospital. So they fly under the radar. They're not like a 23 or a 24-weeker who's been incredibly unwell in the ICU. And okay, this kid has potential for major problems. So you target interventions to help this child. But there are many children who are exposed to prenatal drugs. It's such a massive population, but I think we have we take little steps, and one of the most important little step is to increase awareness of the potential problems that they may have. So to have clinicians and families as well, and the community realize that this child could have potential issues and support them. At the moment, we have no reference base to provide them with any intervention.
Yeah, so I guess on some ways, Lee's asking a question.
Oh, yeah.
In the chat, she said, I was wondering if women in contact with the criminal justice system had been considered as a high-risk group in the guidelines. The intergenerational effects on children of substance-using women with CJS is profound. Those babies on an almost direct trajectory themselves to CJS, and need early intervention, which few get.
Yeah, thanks, Lee. Yes, we did have Jill. Oh my goodness, I forgot the name. Jill. She was Director of Justice Health. Yes.
Robert.
Yeah, Jill Roberts. Yes, so sorry, Jill. Yes, so she was one of our EAG, our expert advisory group, and women or the parents in custodial settings are considered as a high-risk group in the guidelines. Yes, definitely.
Yeah, and I guess it's like, as you said before, a lot of it's about raising awareness amongst clinicians, so that clinicians out there in this webinar, when they see or encounter children in their clinical role where there might be an area of concern, they could think about potentially prenatal drug exposure.
Hi, can I ask a question? We had a case about a few months ago where the mother was actually not allowed to have the child because it worked out that most hospitals are very antenatal care, the midwives, etc., are able to pick up very quickly the mothers who are potentially drug affected. So the child was actually removed. Is that commonly done until it was safe?
Sorry, Olutega, you mean removed from the mother and put into a special care nursery?
Yes. So I think the history I got from the mother was that she wasn't able to access her child. It was quite confusing because I myself wasn't aware that the mother was probably drug intoxicated during her antenatal period, but the child was actually not allowed to be put with the mother. So there are things available for if the hospital suspected or know that the mother has been drug exposed.
Yes, I think there's a lot of variation in clinical care for or care of the mother and infant diet depending on the circumstances. Many hospitals will automatically put children who have been exposed to prenatal drugs into a nursery, and regardless of whether there are any risk factors for safety and health, and that is what we're trying to change. We know from a robust body of evidence that if you keep the baby with a constant carer, whether it's a biological mom or someone in place of the biological parent that can attend to their needs, instead of being in a nursery, being looked after by, with 8 other infants by one poor nurse who's like run off her feet, then their risk of withdrawal or serious withdrawal is much less. And it also disrupts the bonding of the mother or the carer, parent carer figure with the child if they're removed. But of course, every circumstance is different. And maybe in your case, there were other factors involved that necessitated the separation. Yeah. So what we are not comfortable with is an automatic admission into a nursery of a healthy infant if there are no other circumstances, impacting on the baby's safety or health.
That's good. Thank you, Julie.
Thank you. Shall I keep going?
Yeah, keep going.
Yeah, all right, okay. All right.
Is it okay if we interrupt occasionally?
Oh, definitely.
Okay,
So
great. Thank you.
I'll minimize you because I can't see my screen.
Yeah.
Okay. All right. Okay, Dookies. So another thing that we had huge difficulties with on the floor was this like blanket rule: stay in hospital for 5 to 7 days for every single infant. So initially, this guide to hospitalization was developed to monitor for changes in the infant withdrawal pattern from methadone. So many of the infants would have a peak of withdrawal within 2 to 3 days, or sometimes 3 to 4 days. And then the extra couple of days was tacked on to allow clinicians to sort out all the other measures that were needed to have the infant safely discharged from hospital. But over the last, almost 20 years since the first 2006 guidelines were developed, what we've realized is that with the use of buprenorphine and the use of other substances that don't typically cause a withdrawal syndrome in the baby, like methamphetamines, some of these infants are kept for too long in the hospital when they don't need to be in. So substances like cannabis rarely cause a profound withdrawal in the baby unless mom takes a lot of cannabis. And some substances like the SSRIs, for example, the selective serotonin reuptake inhibitors that's used for depression, treatment of depression, and a lot of other mental health issues, mostly have an intoxication effect where the baby is affected very quickly after birth and then rapidly gets better. So what we've done in this guidance is to individualize recommendations for hospitalization. So you can see that we have reduced recommendations for minimum hospitalization from up to 7 days to 5 days. And some of them we've recommended a minimum stay of 3 days. So for substances such as alcohol, cannabis, SSRIs, and gabapentinoids. There is also a clause saying that the clinicians may deviate from these recommendations according to individual circumstances. So there are some babies who may have difficulties, settling or feeding because of the effects of the substances or from other conditions. And then there may be some social issues that may necessitate longer or shorter hospital stays. Ooh. Hang on. The slides are not working. What's happening here? All right. Okay. One of the biggies, one of the big changes in our guidelines are the newborn withdrawal scales. So what we use now and what is used mostly around the world is a scale called the Finnegan Neonatal Abstinence Withdrawal Scale. So that's it on the right side. This is a modified one, and the real, full Finnegan scale is a lot bigger than this one, more than 30 items. You can imagine scoring the baby or doing this assessment on the baby every 4 hours, which is what's recommended by Finnegan. Then Loretta, who developed that in 1975, would drive most, clinicians nuts. So the Finnegan scale was developed as a research tool by Loretta in 1975 based on observations from about 200 narcotic-exposed infants or opioid-exposed infants, and it's been validated for opioid withdrawal. It hasn't changed much since then, but its intricacy and its detailed nature has been responsible for almost eliminating death from newborn withdrawal. It's recommended as a standard care assessment in Australia as well as the WHO, and it again is opioid-centric. It's very, very sensitive. It's able to discriminate between normal and drug-exposed infant behavior, but because it's done by clinicians, excludes many parents or carers from its assessment, it's been implicated in prolonged hospitalization and medication of infants who are at risk of withdrawal. So in the States, when they were hammered by the opioid epidemic, Matt Grossman there from Yale developed this score called the Eat, Sleep, and Console, or ESC. So the hospitals in the US were inundated by babies who were admitted for neonatal abstinence syndrome. It was estimated that about one baby was born with NAS every 18 minutes, and they were staying for months when they were assessed with the Finnegan score. So this distilled NAS assessment to 3 fundamental infant needs, which is to eat, to sleep, and to be happy. The other change was that Matt proposed that the babies be given withdrawal medications whenever they needed, but only after consultation with the baby's carer or parent and with clinicians. So if the baby couldn't eat, sleep, or be happy, they were given, for example, a dose of morphine, reassessed later, and then if they needed, given another dose, or if they didn't need it, not given a dose, which was very, very different to our strict regular timing for NAS medications. So with this score, he reduced the need for medication for babies at risk of NAS by more than 75% in his hospital. And we did a systematic review and meta-analysis of all the QI studies that were done. And we found that, yes, ESC significantly decreased the need for medication and hospitalization in opioid-exposed babies in the US. So I'll just skip through that. There has only been one randomized controlled trial of ESC versus the Finnegans led by Leslie Young from the US, where she randomized 26 sites, screened almost 2,000 infants, but excluded many because many of the hospitals in the US were not able to meet the needs of the Eat, Sleep, and Console model. But what she found was confirming what Matt found was that the use of ESC and a patient-led care model could significantly decrease hospitalization, need for opioid treatment for many babies who are at risk of withdrawal without any change or impact on patient safety. In the States, they have difficulty accessing long-term outcomes. So what she did in this study was she looked at EMR, she looked at media reports for, reports of death or maltreatment, and then she searched public records, and there was absolutely no change. So we have incorporated or recommended an Eat, Sleep, and Console model as an alternative model of care. This is a pretty big change because it requires significant clinician education as well as parental and carer education. So in New South Wales, hospitals are able to use the ESC as an alternative model of care, but we recommend that all hospitals who use this collect data from QI studies. And they should be aware that all the existing data of improvement in hospitalization and medication comes from studies from the US and not from Australia. The ESC model needs a parent or a carer to be present and educated in the model, and we recommend the parent and the baby has to room in together, which means do not separate the baby, put the baby into a nursery unless there's a medical reason. Non-pharmacological interventions such as swaddling, frequent feeds, nursing in a quiet environment are instrumental. And also what needs to be aware of, what clinicians need to be aware of, is that the ESC model, like the Finnegans, is only validated for opioid exposure in term infants. Some of the treatment involves a huge paradigm shift in thinking, in that NAS medication must be minimized and given only on an as-needed basis. There is no safety data beyond 3 months, and there is currently no Australian data. So we're hoping to develop research proposals to evaluate ESC. We're trying to get up a cluster randomized controlled trial of ESC. So if you're interested in it, please reach out and we can talk. We are going to try to put in a couple of grants, hopefully by next year. I'll skip through that. Skip through that. So finally, trust, respect, knowledge are part of our duty of care. We need to form a trusted, therapeutic and non-judgmental relationship between families and clinicians and advocate for lived experience support. We have to continue support before, during, and after pregnancy. And as New South Wales Health says, at least for the first 2,000 days. And recognize that the impact of trauma, discrimination, and stigma can last for generations. We need access to education for both families and professionals to improve our awareness of the situation, hopefully to increase our empathy and our quest for knowledge. So these are all the people we need to thank, and we have collaboration and communication, and we do recommend that your team, this might be a nirvana, have at least some people that are part of this list. So I have to thank a lot of people, including the amazing team at the Ministry of Health. These guidelines took so long that we went through 2 chief addiction medicine specialists, Tony and Deborah. Marissa is still here. She even had a baby in between. And Christina St. John has left for greener pastures, but she's a very clever formatter of the guidelines. This is a new team that has taken over. And if there are any concerns, reach out to us, especially to Madeline, who will revise the guidelines. And of course, Nick Linzeris was instrumental in his support. I found many pictures of him. I think many of you will have many other images of Nick, right? So he is the best chameleon ever. And of course, my students who were very helpful in developing the data that we use for much of these recommendations. So I think I only have 10 minutes left. So in conclusion, the 2024 guidance, not guidelines, for substance use in pregnancy and parenting services encompasses the changing landscape of substance use in pregnancy and parenting. It's not just neonatal abstinence syndrome anymore, and we need to consider a lifespan approach. So what do we need? Specialized services, a one-stop shop to make it easy for families and professionals. Not sure whether that's achievable. We can start with education for ourselves, for families, foster carers, community educators, policymakers, through HETI models, courses, conferences, and meetings, and to fund research to improve outcomes. So before I go off, thank you to our team in Southeast Sydney, the Chemical Use in Pregnancy Service team. We started our outpatient service in 1997, led by the amazing Dr. Feller there. And in that process, we've noticed through our observations a lot of the issues that have affected the families and the children impacted by prenatal substance exposure. And hopefully our work can continue to make their lives a bit better. So thank you.